உங்கள் எல்லோருடையும் இன்றைக்கு இந்த ஒரு நல்ல சந்தர்ப்பத்தில் சந்திக்கிறது மிகவும் மகிழ்ச்சியான விடயம். நாங்கள் எங்கள் நாட்டில் மீண்டும் நாங்கள் மனிதர்களாக வாழ்வதற்கு எல்லாரும் எப்படி சேர்ந்து வேலை செய்யலாம் என்பது தொடர்பாகத்தான் நாங்கள் கழிச்சு கொண்டிருக்கிறோம். அந்த வகையில் உங்கள் எல்லோருக்கும் முதல்க்கு நான் ஆர்கனைசர்ஸ் எல்லாருக்கும் முதல் என்னுடைய நார்த் ப்ராவின்ஸில் ஈஸ்டர்ன் ப்ராவின்ஸில் சார்பில் நன்றியை தெரிவிக்கிறதோட actually I would like to discuss few. I'm not going to talk for I'm very few slides. I'm not going to take much time. Only thing is I want to just explain you the reality, what is in the country, in the northern province, same as in the eastern province. What is the actual situation? So first we should understand, then only we can plan to develop our part of the country. So actually I'm talking about the northern province, and my friend already has actually explained the situation in the eastern part of the province, in the country. So actually the northern province, we have 5 districts, all 5 districts in the map. So earlier somebody was, in the morning session, actually someone was asking the population of Jaffna district. So that's what I thought of just showing you this slide. So the total northern province population is 1.2 million. And the land area is nearly 9,000 square kilometers. So this is about our province. And so actually there were many questions. Why there is a need for public-private partnership? Are we going to penalize the poor people there by introducing the public-private partnership? And many of you actually visited after 2009, even before. Actually, I met the colleague, Dr. Ganeshan, in Kilinochi once upon a time, in I think 2004 and 2005 when I was working there. So many of you before 2009 and after 2009 visited our province. So there's a big difference actually before and after 2009. Before 2009, even though we had very limited human resource, very limited infrastructure facilities, we all wanted to do something for good. So all were working very hard. Even though we had less facilities, supplies, very limited number of people, the medical professionals there, we never had an outbreak of infectious disease in the northern province. But now, after 2009, compared to those days, our infrastructure is a little bit better. We have our human resource even a little bit better. We have more people. The roads are very nice roads, carpet roads. We have many ambulances compared to those days. And you can talk free a little bit. And people are talking about, good governance. So many changes are there. But just analyze the situation before and after. We are still, there is no much improvement. Even after 6 years, after the end of the war, for 6 years, there is no much improvement. So there should be a reason. Actually, before 2009, we had some reason why there is no good service or better service. So now there are many reasons. I think the first reason is I don't want to ask finance, anyone. Actually, this is not asking finance. We didn't come here to actually ask donations. We ask you people kindly to invest. The investment may be money, but your knowledge, your experience, your support, this investment we need actually to improve the situation, improve the health facilities there in the northern province and also of course in the eastern province. So this is actually the structure of our health system. In our Ministry of Health or the Department of Health, I'm the minister now, and I have one secretary and two additional secretaries. They are non-medical people. The provincial department, there is a director of provincial health, we call PDHS. It's a medical doctor with the experience, a lot of experience, and the grade 1 medical administrator. Under her there are 5 regional director of health services. They are the people actually in charge for the administration and run the district level administration and providing the facilities or the services, health services. So there are 5 people there. They are also qualified, they should be qualified medical administrators. Unfortunately, we have only 1 out of 5, 1 qualified medical administrator. What about the other 4 districts? They are administrators. They are very junior medical doctors. They are without any additional salary. They are covering up the duties of the qualified medical administrator. So what I am trying to tell you is the human resource problem is a huge problem. This is the bottleneck to provide better or good healthcare service to our population. So actually we have, altogether 110 hospitals in the province under the provincial ministry. The Jaffna Teaching Hospital is directly coming under the line ministry or the central government. Other than Teaching Hospital Jaffna, we have 110 hospitals. So here there are, there are different grades of hospital. So in the provincial ministry, we have 4 general hospitals. Other than Jaffna, other 4 districts, we have 4 general hospitals. Jaffna, there is a teaching hospital. And the bed strength in all 4 general hospitals, nearly 1,000, 1,500. And there are base hospitals. There are 2 types of base hospital, type A and type B. We have 2 type A hospitals in Jaffna and type B base hospitals in other districts. Altogether we have 7 base hospitals and the divisional hospitals. Maybe there are senior doctors who worked earlier in our country, those days it was named as CD, Central Dispensary, CD and MH and divisional hospital, base hospital, like that. So now this is the new name we are using. So there are divisional hospitals, 56, so altogether 110 hospitals. The pathetic situation there is, out of 110 hospitals, 36 hospitals, when I took the ministerial post, not a single doctor available in 36 hospitals. So anywhere, somebody asked, what about in the other provinces? They have problem. Similar problems they also having in other 7 provinces. They have the same problem. They have problem. We have, in addition to the problem, whatever they have, we have some specific problem. That is what we are trying our best to cooperate and coordinate, get collaboration from many parts of the world and to improve the health system there. When I spoke to the Minister of Health in the central government, Dr. Rajita Senaratne, is a very a good doctor. He is a dental surgeon. I think You lectured him in the faculty, Peradeniya. So he is a dental surgeon actually by profession, and he is a good man, mankind. He is not actually showing the difference between the south and the north. Whenever possible, actually he help us. So, what I am trying to say is, when I set him in when I met him first time, you know the situation there. He said, yes doctor, you know, this is after war, post-war time. Of course, any part of the world, the post-war situation is that. I said, okay, I also know the globally post-war situation, you have problems, but we have problems. Maybe the other part of the world, they don't have those kind of problems. 1/3 of the hospital where there is no doctor. Without a doctor, how can you call that hospital? Then he said, I'm sorry, I didn't know that, so I will help you. And he helped, he sent some MOs. Now nearly 29 out of 36 hospitals where no doctors. Now I have 5 hospitals, there are doctors. So rest 29 hospitals, still no doctors. So where are we? This is the thing actually, where are we expecting your support? Now these 29 hospitals are not closed. We are running the hospitals. So you may think, without a doctor, how you are running the hospital? There are doctors. We re-employed some RMOs, very few medical officers. The problem is, the medical doctors, after retirement, you can't find them in Jaffna or in the north or eastern province. Their children, maybe London, all over the world. So they retire, and also they want to pass the time with their grandchildren. And even sometimes they are forced to come here, to look after the children. So they all usually come. We are actually we are unable to find retired doctors there. So very few retired doctors are there. So we employed them, and now they are working in those hospitals where there is no official doctor. And also officially or legally, we can't employ pre-interns, the doctors who just passed out the university and waiting for internship. So after the internship only we can call them doctors. So they are legally allowed to work after the internship. But that also a problem. After the internship, every year Jaffna Medical Faculty is producing nearly 130 doctors. So you don't believe, I think 20-25 doctors are coming back to the north to work. Where are others? They are in the final year, they start studying for PLAB, for AMC exam, and many, we can't blame them because the situation is that. They are trying to migrate, many of them are successful and they are migrating. Many people, they say, many doctors, they say, there's no facility in the province, there is no PGIM, so we want to study, so we have to go to south. And they go to south and they work there and study. And other group of doctors, they say, you have no private practice, the salary is so low, I have to maintain my status, I have to purchase a car, I have to have a good house. So they are saying there is no opportunity in the northern and eastern province to earn money. So they go to Colombo or Kandy, they do locum and they earn money. We can't blame them, they are doing that. So the human resource in our province, not only of course the eastern province is far better compared to the north. The human resource is the bottleneck to develop good health services in the province. So we are forced to, our line ministry said, no, don't employ the pre-interns. If something will happen, legally you have to answer. You cannot pay money from your ministry allocation. So what we are doing, there are nearly 15 or 16 pre-interns alone, without any supervision of a senior doctor. They are working. In Jaffna, mostly in the islands, in Vavuniya, Mullaitivu, Kilinochchi, all over the northern province, the pre-interns are working. If pre-interns are not there, we have to close. So who is paying to the pre-interns? Of course, you people are paying. IMHO is paying, and AMAF is paying. So they are directly, we don't want to get money on our account, because people are checking whether Dr. Sathiyalingam is getting money from diaspora. They have inspected it's actually really, many times the CID went to the bank officers calling me, doctor, in writing they have written to our manager, Bank of Sloan or other banks, the details, because they still suspect that we are getting a huge amount of money from diaspora. So what we asked the doctors, AMA, or MIOT or IMHO, please, you pay the pre-interns directly. So they are paying, the doctors are working. So this is about doctors. And also same, the next slide you can see, this is the situation. For example, medical consultants in the northern province, there should be 119 medical consultants. We have only 60, half, 59 vacant. So medical officers compared to the medical consultants, it is little better. Still there are 178 vacancies. And nursing officers, the same problem. And you may ask me, the nursing officers, 826 is the approved cadre. You have nearly 692 is 700, so only 100 lacking. They have done the cadre revision long ago. They have not revised the cadre for a long time. So population growth is there. New hospitals are established. New units are established in the existing hospitals. Now there is a huge need. We have already, last year, more than a year, we have actually revised the cadre positions according to the needs and sent to the central government. Actually, you should know the capacity of the provincial council under the 13th amendment. We can, put the fish into the tank, but we can't catch it. So you can just, it is the situation of the provincial council. So other than the minor staff who is actually cleaning the hospital, all the staffs are recruited by the central government. We have to get the treasury permission. So we have actually given, but still we are waiting for that. So the human resource is a problem. So this is the bottleneck, actually, especially the medical officers and the medical consultants we have highlighted here, because without medical consultants, it is very difficult to provide a high quality service. So this is few slides actually I wanted to show you. The malnourished children, 2 to 5 years, the moderately acute malnourished people. The Sri Lankan, the first one is the brown color is the Sri Lankan our country data, and all other 5 districts you can see. But for example, the blue color is Kilinochchi. It is in 2011, the MAM is very high. Now you can see the blue is becoming small. There is an improvement, it's there. But still, when you compare with the other provinces, the data, the malnutrition of other provincial data, still we are in a very high actually. And also, somebody, I think you raised a question actually, the data collection. This is actually, I am not saying this data, whatever I am presenting, is actually not representing the actual situation. Because how we collect this data? The medical staffs, the primary healthcare staffs, they generate this data. If we have 50% of the data collectors, of course we have the data is 50%. So we don't have the entire data because there are places where there is no public health midwife or public health inspectors. So the data, and the other thing is the method how we collect data. Actually in Sri Lanka there is a very good system of collecting data if we have professionals, if we have the medical staff there. It is the best system, I think, in Asia. We have a very good public health report system is available in the country. But unfortunately, we are unable to use that system because of the human resource. So anyway, this slide says something, the message is, there is an improvement, but still we are higher than, or compared to other part of the country, we are still in danger. And this is severely acute malnourished children, SAM, also almost same. So it is very high when you compare with the Sri Lankan standard, Sri Lankan data. So this is actually pregnant mothers with low BMI. This is actually Sri Lanka as the blue one. So just compare other districts. Again, you may think Jaffna is far better than Sri Lankan data. It's also, again, the same reason. For example, Jaffna municipal area, there's not a single midwife. So the BMI is taken by the data maternal health, the midwife is doing the things. So municipal areas, more than nearly 200,000 population. So there is no midwife. So again, there's a problem, and also we are unable to present the actual situation because of this issue. And again, this is pregnant mothers with moderate anemia. Same. So what teenage pregnancy is a social problem actually. The teenage pregnancy is in Mullaitivu, Kilinochi, Vavuniya, is more than the Sri Lankan 5.3. Mana and Jaffna, same reason. Mana is the worst place where the less number of public health staff available. So the slide you can see it is less than the Sri Lankan number, but actually this is not the situation. So what I am trying to say is, this is a huge problem for us. It's a social problem. Teenagers are getting pregnant, and because of this, there are illegal abortions. They are just throwing the kids on the road. There are children homes. There are, conflicts between families. So this is a social issue, of course a medical issue, but as Dr. Sveyohan's presentation he said, it is we have to have a multi-sectoral approach to minimize this kind of problem in our province. So these slides, whatever I have presented here, we are talking about the future. We are talking about the future generation. But when you think the pregnant mothers are malnourished, children under 5 years are malnourished, there are teenage pregnancies, how the future will be bright? Because we say, எங்களோட குழந்தைகள் எதிர்காலத்தின் முதுகெலும்பு. ஆனால் முதுகெலும்பு இல்லாத குழந்தைகளை ப்ரொடியூஸ் பண்ணி கொண்டிருக்கிறோம். நாங்கள் இந்த சிஸ்டம் இந்த நிலைமையை மாற்ற வேணும். நாங்கள் எல்லாரும் சேர்ந்து இதை மாற்ற வேணும். இப்போ இதில் இஷ்யூஸ்ன்னு சொன்னதுதான் இந்த விஷயம் இருக்கு. எங்களோட மோபிலிட்டி அண்ட் மோர்டாலிட்டி. The non-communicable disease is a evolving problem as in other part of the world. இப்போ நீங்கள் பார்த்தீங்கன்னு சொன்னால் the CKDU, we write CKDU, it's unknown origin, chronic kidney disease, unknown origin. There are a lot of debates. People are saying the hypothesis there because of water. So water problem in Jaffna, the water problem in other places. But compared to other districts, the northern province is in the second place. The north central province is the highest number of CKD patients are living in the north central province, especially Anuradhapura, Polanaru area, because a lot of agriculture wells and a lot of agriculture, paddy fields. People are using the groundwater, where we are using uncontrolled pesticides and fertilizers, insecticides and many things, many chemicals are used. The same thing in our province. Our irrigation system is that we are using the same groundwater, so maybe that is one of the reasons. And the second reason why we are talking about primary health care, there are, nations, we have the prevalence of diabetic hypertension is very high. Our diabetic patients are diagnosed. I was diagnosed when I lost 15 kilograms, very recently, 3 months ago. Maybe the reason is, of course, something else, but people are coming to the hospital. When a CVA patient comes to the ICU, and then only the family members, even the patient knows, I'm hypertensive. So this is the situation. So where we diagnose them? It's of course the primary care. It's not in the tertiary care unit. So in our province, and also in the eastern province, it is very important, necessary to develop the primary healthcare services. So we are in a situation, the 30 years of war has devastated everything. We lost not only lives, our economy, our culture, our beliefs, our norms, everything is finished. So now we have to actually come from the bottom. So this is, if we can come up, we should be a healthier nation, healthy population. So this is the non-communicable disease. Again, it's a threat. It's a threat. Not only the diabetic or CKD, the cancer. It's in the number of cancer cases raised. So maybe the reason there are many reasons people are saying, the chemicals, the bombs, and many things they are saying. But whatever the reason, it is increased. So in the presentation, Dr. Swendra Kumar's presentation, the cervical cancer is, compared to other cancers, it is less in the province. I don't think it is less, because we are not screening. Who's screening the cervical cancer? Of course, it's the primary health care services. So we are not doing that properly. We are doing wherever we have staffs, where there is a medical officer, we are doing. But still, it is the lack. So we cannot actually interpret in a correct way the data, whatever we have. So rightly he said, we have to have a system. So now actually in our, maybe I'm taking much time, but I think it is, you need to know, it is the basic actually. Without knowing the situation, fundamental problems, we cannot do anything. So this is actually, okay, I will go a little fast. The primary healthcare services, now, we have to develop it. We are going to spend a big amount of money, whatever we get. Our strategy plan. Actually, when I took this post, I thought we have to have a plan first. Without plan, ad hocly doing things here and there will never the good results. So we thought of having a good strategic plan. Of course, Dr. Surendra Kumar and Dr. Sivayog and other consultants as a specialist, and also the doctors and non-medical people even, they supported very well. We worked for more than a year, and the strategic plan for 3 years is in our hand. So according to the plan, actually we are not going around the plan. Now the task is to implement the document. It should come into the action. So now to bring this into the action, we have developed, I will come later. So this is the most common important issues whatever in the province. I think Dr. I forgot your name, the convener here. You are very tense, I think, because the time is going on. So I think whether you know all these problems actually. I will just explain a little bit about the strategic plan. So we have actually identified 15 areas where we have to have more attention, and we have actually developed, and now there is an implementation plan actually what we are now this is the actually we are planning, already we are establishing executive board, and then there will be executive committee, and in the executive board there will be clinical experts, public health experts, mental health experts, and all experts and academics, and of course to the committee there will be honorary consultants and other members, and of course we are actually expecting the international experts to be in this executive committee, because in all, now actually we have many specialists actually in all over the world, the Tamil-speaking people who actually would like to work in the province, the north and east. Actually, we want to have them also in the committee to go forward. And then we summarized, and there were 15 components. Now we made it to 9. We amalgamated some of the related fields, and there are 9 subcommittees will be there. And subcommittees, of course, there will be the related specialists and other experts, and we will, of course, support these groups, and they will be advising from bottom to top, and we are trying to, in this way, we are trying to implement the plan actually. So now I would take a little time to explain the other problems what we have. Actually here there is a separate subgroup will be looking after the disability. Now in the province there are nearly 5 groups of people who need more attention, or the most vulnerable groups in the society. The first most vulnerable society or most vulnerable group in our society is people with differently abled or people with special need. So you don't believe our population in the province is 1.2 million. Out of 1.2 million, there are 42,000 disabled. So which is, when you compare with other part of the country, of course it is due to war. Maybe the situation in the northeast also same. It's nearly half lakhs, 42,000 people are there. So now what we do is, we have to have actual data. Now our staffs, the trained people. They are going house to house. We are doing that data collection electronically. The Asia Foundation is supporting for that. We are about to finish in Kilinochchi district, where we have more disabled, Kilinochchi and Mullaitivu, the worst affected area. And still there is a limitation for us. We are unable to start all over the province because we are using the small PC tax. Because why we are using the PC tax? There will be no errors. Then and there you get information summaries in the programs, and also we are trying to establish the medical information system in the province, electronical, so you will get everything in time. Otherwise, you have to wait. The data generation manually, it will take a lot of time. So we are trying to do this. This is, of course, it's not big investment, but for the province, northern province, it's a big investment because we have to purchase these PC tablets. So we are now, I think AMF also will support us to purchase some more. So anyway, we are trying to go each and every house. It's like a census. This is the first stage of collecting data on disability. And second stage, only our staff will go with the different type of data sheet. Only the special need people's house only. Now they are going each and every houses. So there are many people, they don't know they are differently abled. So there are many people, they don't know they are differently abled. So we have to visit each and every houses. The second group, most vulnerable group is women-head households. The women-head households, his number again is 45,000. So the women-head households, maybe they are widows, or the husband is missing, or husband is in jail, or any other reason. This is the second most vulnerable population in our society. You may not know, in Sri Lanka, the Kilinochchi district is the first in the list consumption of alcohol. Before 2009 and after 2009, so just imagine, the Kilinochchi district is the district in Sri Lanka consuming more alcohol. It is illicit alcohol, khasipu. So these 45,000 women, most of them are doing this business. They are not producing. People are producing and selling. This they are giving to them. They are selling. In the evening, they get nearly 750 rupees per day. So we can't blame them. They have no other choice. So these are the second vulnerable group. And third is the ex-combatants. There are nearly 15,000, 14 to 15,000 ex-combatants. Most of them, they join not only LTTE, other movements. In young age, they don't know any job, or their educational qualification is so low, they can't join the government sector or even the private sector. They are only the manual laborers, most of them, the majority of them. There is no, after 2009, there is no much new factories, or there is no job opportunity. So these people are also, again, most of them are forced to go for illegal business. And the fourth group is the orphans. And the fifth, parents, single parents, or the parents without their kids. So this is the 5 most vulnerable population living in our society. So, after looking or thinking of all of this, we thought of having some kind of idea how we can improve the health system. How we can improve the health system with other areas. So the answer may be, it is partnership. The partnership is how we can achieve the goal is partnership. Maybe the partnership within the province, maybe within the country, and of course with the other part of the world, especially with the diaspora. So that's the reason why today actually here. And I think it is a golden opportunity for us. And also for me as a medical doctor, worked in the north from 96. I worked there nearly 18 years in Vaunia and Mullaitivu district. And we have seen what happened there. So it is my duty and the responsibility. During my period, I have to at least, if maybe I am not going to do wonders, but at least I have to lay the foundation. And then the people who come, this is enough, I think. The politics is too bad. It is very difficult to be a politician. So today also in the morning I discussed with my colleagues here. It is for a doctor, suddenly all of a sudden switch on to the politics. It's very difficult, and sometimes you can't bear what the society is talking about you. When you work as a doctor, you are a good person, and you are the leader of the society, and maybe the genetics, our people, they try to, they never work together. So this is the history, I don't need to tell you. So it is actually my ambition is to at least to put the foundation. And of course the future generation will come and do the rest. Thank you very much.